Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to med school. Topic for this video is unstable angina and NSTEMI. Myocardial infarction is classified as acute coronary syndrome when patient is having acute onset of symptoms like chest pain, palpitation, sweating, etc. If there are tall peak T wave inversion or ST depression, then level of cardiac marker should be done. If cardiac markers are normal, then it is unstable angina. If levels are raised, then it is non-ST elevation myocardial infarction or NSTEMI. When there is ST elevation in two or more contiguous leads, then it is ST elevation myocardial infarction or STEMI. In old or evolved MI, there are pathological Q waves in ECG. This video is going to elaborate unstable angina and NSTEMI. ECG changes like tall peak T wave inversion and ST depressions are discussed in details in previous video. If you haven't watched that video, please go through it first for better understanding. Link for the same is given here. To understand unstable angina, let's decode its name and let's first understand what is the meaning of angina. Angina is a symptom described as chest pain. But patient can also describe it as chest tightness, chest heaviness, burning sensation or fullness sensation. Angina most commonly involve retrosternum, left side of chest, epigastrium and left arm and forearm. Less commonly, angina can also radiate to back, shoulder, neck and lower jaw. Now let's understand what is the meaning of unstable. Angina is called unstable when it occurs at rest, becomes more frequent, severe or prolonged than usual. There is change in pattern of angina and angina is not responding to rest or nitroglycerin. As we have already discussed, in addition to symptoms and ECG changes of unstable angina, if cardiac biomarker levels are also elevated, then it is non-ST elevation myocardial infarction or NSTEMI. Cardiac biomarkers are molecules which are normally present in myocardial cells and released into circulation upon myocardial injury like necrosis due to ischemia. So, presence of these markers is an indicator of myocardial necrosis. Cardiac biomarker commonly used in clinical practice are troponin I and T and creatinine phosphokinase MB fraction. Both these biomarkers appear in blood 3 to 6 hours after the onset of symptoms. CPK-MB reaches its peak at day 1. Levels gradually decreases thereafter and comes back to normal at around day 3. While troponins reaches its peak at around day 2. Levels gradually decreases thereafter and comes back to normal at around day 7. As CPK-MB comes back to normal at day 3, it is more useful biomarker than troponins in evaluation of reinfarction. Suppose patient got reinfarction at day 5. Troponins level will not be useful because levels remains elevated due to first infarction. But raised CPK-MB level on day 5 can be an indicator of reinfarction. Now let's understand what is TIMI score. Some patients of unstable angina or NSTEMI are high-risk patients who can progress to STEMI, have recurrent ischemia or may die. Thrombolysis in myocardial infarction or TIMI risk score is designed to identify such patients. This scoring system has 7 variables. Presence of each variable carries 1 point. If TIMI score is 3 or more, patient is categorized as high risk. Variables are age more than 65 years, use of aspirin in preceding 7 days, known coronary block 50% or above, elevated cardiac biomarker level, presence of at least 3 risk factors for coronary artery disease out of the following, which are diabetes mellitus, hypertension, dyslipidemia, family history of CAD and history of smoking. Next variable is presence of 2 or more anginal events in last 24 hours and presence of ST deviation on ECG. If patient is categorized as high risk, patient should be treated in intensive care unit and subject to percutaneous coronary intervention as early as possible. There are some atypical changes which also suggest myocardial infarction. Recent onset left bundle branch block or LBBB is one of them. So ECG like this can indicate MI, provided baseline ECG is available for comparison and does not have LBBB features. Only then LBBB can be called as recent onset. If you want to learn more about LBBB, you can check out this video. Another example of atypical ECG changes indicating myocardial infarction is Wellen syndrome. It has 4 characteristics. First is history of anginal chest pain, then normal or minimally raised cardiac markers level, presence of deep T wave inversion or biphasic T waves in lead V2 and V3, and no ST elevation or pathological Q waves, and presence of normal R wave progression in precordial leads. Wellen syndrome is very important as it indicates critical left anterior descending artery stenosis and frequently converts to anterior wall STEMI. There are biphasic T waves in lead V2 and V3. There are no ST elevations and no pathological Q waves. R wave progression in precordial leads are normal. So this ECG can indicate Wellen syndrome provided patient is having anginal chest pain and cardiac biomarkers levels are normal or minimally raised. Similar to Wellen syndrome, de-Winter T waves is also an example of atypical ECG changes indicating myocardial infarction. It also has 4 characteristics, which are tall, prominent, symmetrical T waves in precordial leads, upsloping ST depression more than 1 mm in precordial leads, absence of ST elevation in precordial leads, and reciprocal ST elevation which is typically 0.5 mm to 1 mm in lead AVR. Similar to Wellen syndrome, de-Winter T wave also indicate critical LAD stenosis and frequently converts to anterior wall STEMI. If you observe complexes in lead V3, there is ST depression which is more than 1 mm along with tall peak T wave. Somewhat similar changes are present in lead V4. There is 1 mm ST elevation in lead AVR, while there is no ST elevation in precordial leads. So these changes are typical of de-Winter T wave. There are 4 objectives in treatment of unstable angina or NSTEMI, which are to reduce symptoms, to decrease myocardial oxygen demand, to improve myocardial blood flow, and long-term therapy for prevention of future events. Nitrates are the most commonly used agent to reduce anginal chest pain. Isosorbide mononitrate or dinitrate or glyceryl trinitrate are commonly used. They are contraindicated in hypotension or inferior wall ischemia. Morphine or buprenorphine is used for severe chest pain not responding to nitrate or when nitrates are contraindicated. When there is a reduced blood flow to myocardium, decreasing myocardial oxygen demand can reduce symptoms as well as myocardial damage. Myocardial oxygen demands depends on 2 factors, heart rate and blood pressure. Both these factors can be controlled with beta blockers like metoprolol, carvedilol or nebivolol. They are contraindicated in acute heart failure and cardiogenic shock. As we all know, arterial thrombi are platelet-rich. Hence, antiplatelets are the mainstay in antithrombotic therapy of acute coronary syndrome. Antiplatelets halts the progression of thrombus formation and shifts the equilibrium toward thrombus dissolution. Aspirin is the most important antiplatelet of all. It belongs to non-steroidal anti-inflammatory drugs. Loading dose of aspirin is 325 mg followed by maintenance dose of 81 to 325 mg once a day. Aspirin is most effective and continued lifelong after an event of acute coronary syndrome. Clopidogrel is the most commonly used adjuvant to aspirin. It belongs to thienopyridine group. Loading dose of clopidogrel is given only when patient is younger than 75 years and dose is 300 mg per orally. Some studies recommend loading dose of 600 mg. Maintenance dose of clopidogrel is 75 mg once daily. Prasugrel also belongs to thienopyridine group. Its loading dose is 60 mg per orally followed by maintenance dose of 10 mg once daily. Efficacy of prasugrel is better than clopidogrel, but bleeding risk is higher. Prasugrel is not recommended in patient with history of stroke and prior to percutaneous coronary intervention due to risk of bleeding. Ticagrelor belong to non-thienopyridine group. Loading dose of ticagrelor is 180 mg followed by maintenance dose of 90 mg BID for 1 year after an acute event. Ticagrelor is the only antiplatelet other than aspirin which is recommended to be used beyond 1 year after an acute event. However, beyond 1 year, its dose should be reduced to 60 mg BID. Ticagrelor is combined with low dose of aspirin which is not more than 100 mg as higher doses of aspirin reduces effectiveness of ticagrelor. It should be noted that any one of clopidogrel or prasugrel or ticagrelor is combined with aspirin for 12 months post-acute event as dual antiplatelet therapy. The second most important antithrombotic agent after antiplatelet is heparin. Types of heparin commonly used in acute coronary syndrome are low molecular weight heparin and unfractionated heparin. They are commonly used till 2 to 8 days after the event or till percutaneous coronary intervention. Loading dose of LMWH is indicated in patients younger than 75 years of age. Dose is 30 mg IV bolus and 1 mg per kg subcutaneously. However, total dose should not exceed 100 mg. Maintenance dose is 1 mg per kg subcutaneously 12 hourly. LMWH is preferred over unfractionated heparin because of predictable effect. Loading dose of unfractionated heparin is 60 to 70 units per kg IV bolus, maximum dose being 5000 units. Maintenance dose is started by IV infusion with 12 to 15 units per kg per hour, maximum dose being 1000 units per hour. APTT is monitored 8 hourly and dose should be adjusted to maintain APTT between 50 to 70 seconds. Lipids play important role in thrombus formation and propagation. Hence, statin like atorvastatin should be started as early as possible with maximum dose of 80 mg once a day. There are some newer agents which are being studied extensively for use in acute coronary syndrome. GP2B3A platelet receptor inhibitor like tirofiban and eptifibatide are used when conventional antiplatelets are contraindicated. They are also used with percutaneous coronary intervention. Direct thrombin inhibitors like hirudin, lepirudin and bivalirudin are potential alternative to heparin. Coronary angiography and revascularization with percutaneous coronary intervention for significant blockages should be done as early as possible. However, it should be done immediately if there is cardiogenic shock, severe left ventricular failure, angina refractory to medical therapy, acute mitral regurgitation, new ventricular septal defect, and unstable tachyarrhythmias. Long-term therapy is given to prevent further events. Dual antiplatelet therapy is continued till 12 months, then only aspirin is continued lifelong. Statins are also continued lifelong. There is progressive cardiac dysfunction after an event of acute coronary syndrome. This is called as cardiac remodeling. To prevent cardiac remodeling, beta blockers like metoprolol, carvedilol or nebivolol ACE inhibitor like ramipril, aldosterone antagonists like spironolactones are used. Control of CAD risk factors like diabetes mellitus, hypertension, dyslipidemia, and lifestyle modification like cessation of smoking, regular moderate exercise, and dietary restrictions are very important. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.